So now for our discussion on orthogonal testing, and I am not a epidemiologist. I am not a biostatistician. I learned a lot in preparation for this talk about why our facility is doing double testing. I know many facilities are doing testing, and that's great, but orthogonal testing may be better, and I hope to show you why that's important. So there's antibody tests and there's nasopharyngeal PCR. You're likely all aware of those options. PCR involves a nasal swab. If it's done right, it's very uncomfortable for the patient. We joke that's a brain biopsy. The patient should cry afterwards if it was a good swab, because you really do have to go quite deep. For antibody tests, there's a handful of antibody tests available. None of them are FDA approved per se, but they are EU approved or EUA approved. That's emergency use authorization. The one that we use is Ortho Diagnostics. This is not a sales pitch for a specific antibody test. That's just the one we use, so I can speak about that a little bit. But it seems to have the highest sensitivity and specificity, as well as be a total antibody test for IgG, M, and IgA. So a little throwback to medical school. You may remember from immunology that we have various antibodies that typically come in phases after exposure to a given antigen. So on the x-axis is days since symptoms of COVID-19, and the y-axis is your positive rate. So you can see that a good PCR, and of course that was how it was diagnosed in these patients, so starts at 100%, but that same patient who initially tests positive, the PCR goes down over time. But the antibodies take a little while. And so the antibodies of IgG and IgM, counter to what we have learned for other diseases, IgM is supposed to come first and IgG second. IgM and IgG in this disease seem to come at about the same time and rise about the same time. And so understanding that IgG may actually be present in a acute infection, and IgM may be present in a latent infection is important. So this is a chart that shows you something very similar, but understanding sensitivity is important. So sensitivity is the likelihood of finding a positive if someone is truly positive. So you can look here, RNA is your PCR test. The sensitivity of your PCR test in total is around 67%, 66%, and that's highest right at onset, right? And after a week, that number falls to basically a coin flip. And so after a week, half of your patients who are actually positive are no longer going to show up positive on a PCR. Now, if you look at the antibody tests for total antibody test, and that's there in the orange or brown, your sensitivity in total is about 93%, and initially the sensitivity is not great, 40%. But that number rises over time after 2 weeks, then certainly after 3 weeks goes up. And when you combine the two, that's all the way on the right, the blue. When you combine the two, your sensitivity is highest of all the columns, and so your sensitivity early on from days 1 to 7 is about 80%. Day 8 goes to almost 100%. After day 15, 100%. So positive and negative predictive values are determined by the percentage of truly antibody positive individuals in a tested population. So understanding the prevalence of the disease is important. So when a test is used in a population where prevalence is considered to be low, and right now even in the biggest hotspots in the country, Dallas being one of them, the prevalence is still considered to be low. When the prevalence is low, the positive predictive value drops because of the number of false positives that you get, because the pretest probability is low. Likewise, the negative predictive value is also affected by prevalence. So in a high prevalence setting, the negative predictive value declines, where in a low prevalence setting, it increases. So this is important because when you combine the two tests together, you're more likely to pick up your patients with a good sensitivity. So in the current pandemic, maximizing your specificity and thus the positive predictive value in a serologic algorithm is preferred. So, in a population where the prevalence is, say, 5%, and you're using a test that has 90% sensitivity and 95% specificity, those sound like really good numbers, 90% sensitivity, 95% specificity. But in a prevalence of 5%, a positive predictive value is only 49%. So less than half of those testing positive will truly have those antibodies that showed up. So alternatively, the same test in a population with antibody prevalence exceeding 52% has a PPV, or positive predictive value, of greater than 95%, meaning less than 1 in 20 testing positive are actually a false positive. So when you consider all of this, what are your strategies to properly screen patients with good reliability to ensure that you're not operating on people who have COVID? Well, there are sort of three strategies. One is find a high specificity test greater than 99%, and that should be good, and that you'll have a very high positive predictive value. Another strategy is testing people with a high pretest probability, but of course, patients with a high pretest probability who are having fevers, cough, chills, congestion are probably not getting elective bariatric surgery anyway, so that's not useful. And since the perfect specificity test doesn't exist, you're left with your third approach. And your third approach is to employ an orthogonal testing algorithm. In orthogonal testing algorithms, two tests are used, each with unique design characteristics. And when you combine those two, you tend to get the most reliable result. So in summary, two tests are needed to feel comfortable that the patients that you're operating on are truly COVID positive or COVID negative, hopefully not COVID positive. So how do we use this information? So there are sort of three parameters, or maybe 3.5. You want to look at their COVID history, whether they've had symptoms and how long ago those symptoms subsided, their serology, and their PCR. So ultimately, the interpretation, if you're going to operate, should be that you're treating them as they're COVID negative. And so this would mean that obviously if someone has no prior history of symptoms, they have negative serology and negative PCR, hopefully you're good to go. If they've had symptoms but they've been gone for greater than 14 days, serology would be expected to be positive and their PCR negative, so they should be good to go. And lastly, if they've had prior symptoms of COVID, but they've been gone for 14 days, but the serology and PCR is negative, you can go ahead and treat as COVID negative. That last one is probably people who had some other upper respiratory symptoms with symptoms that overlapped with COVID, but they may not have had COVID at all. You see a red box next to the middle option there, the prior COVID with symptoms that have subsided for greater than 14 days with a positive serology. In our practice, we would wait 28 days before restarting the process. Hospital policy is currently 14 days, but I'm okay waiting 28 days in those patients. And I should say that the system works. In fact, last week we found one of our patients who had no symptoms at all. She came back as PCR positive and serology positive, but no symptoms. So we called her to cancel her surgery the day before her operation. She was very upset, and understandably so, but we said we have to figure this out and give it time, see what happens. She called us the next day and said, thank you for canceling my surgery. Today I'm having fevers, congestion, chills, and so it's a good thing that she didn't end up getting surgery, otherwise it could have been very problematic. So the system works.